How's it going, guys? We have a pass level question, Neuro Step 1, Family Internal Medicine 2CK. Before we get started, please subscribe to my channel. I really appreciate it. Give it a like, really appreciate it. Find me on Instagram, Mehlman_medical, MHLMN_medical, links down below. Find me on Telegram, links to the Telegram group channel down below, and start the clip. 26-year-old man with cluster headache. And we know it's cluster headache because he fits the classic demographic of a male 20s to 40s who's awoken from sleep with an 11 out of 10 lancinating / stabbing pain behind one of the eyes. And he has anisocoria, sophisticated way of saying the pupils are different sizes. The NBME vignette can say that there's an ipsilateral miotic pupil. There can be ipsilateral lacrimation, sometimes even rhinorrhea. The etiology / cause of the pain is uncertain in the literature, thought to be due to hypothalamic regulation because it tends to occur hypnagogically while patients going to bed or awoken during sleep in the middle of the night, and also changes / flux in blood flow in the brain during that moment. So this patient has come in and is not currently experiencing an acute episode, but we're asking what we can do pharmacologically. Let's just whip through the answers. Choice A, 100% oxygen, wrong fucking answer, because this in theory could be used to abort an acute episode. Okay, so wrong fucking answer. Choice B, acyclovir, wrong fucking answer. DNA polymerase inhibitor resistance going to be altered absent viral thymidine kinase, going to be used for HSV 1-2 as well as VZV for shingles, herpes zoster. So even if we wanted to entertain the notion, even if we wanted to conjecture that this patient's pain could be attributed to Ramsay-Hunt syndrome type 2, holy shit, where you get a Bell's palsy, herpes zoster ophthalmicus, that it's a herpetic neuralgia of sorts, or herpes zoster ophthalmicus. Okay, so even if we wanted to conjecture along those lines, acyclovir is not how we treat the pain. This would treat the shingles, the VZV, but for the pain we use gabapentin in that setting. Acyclovir, wrong fucking answer. Choice C, carbamazepine, wrong fucking answer. So this can be prophylactic for trigeminal neuralgia, which can be misconstrued for cluster headache. So trigeminal neuralgia is going to be, it can occur in any distribution, V1, 2, 3 for the branches of the trigeminal nerve. So ophthalmic branch, maxillary branch, mandibular branch, and it's thought to be due to narrowing of the foramina. Okay, superior orbital fissure, foramen rotundum, foramen ovale. Standing room only is the mnemonic for the exit points for V1, 2, 3 respectively. And there's an NBME question floating around where they ask what part of the brain is fucked up and a patient has trigeminal neuralgia, and the answer is pons. Students are confused because they think it's an actual nerve issue, not a brain issue, but if we're forced to choose, trigeminal nerve comes off the pons. So the presentation for trigeminal neuralgia is going to classically be mild / minor stimulus, i.e. brushing hair, brushing one's teeth, flossing, gust of wind. Okay, so those can precipitate an episode, which will last on the magnitude of about 30 seconds maximum. So abortive therapy is more supportive. Okay, there's no specific treatment. 100% oxygen is wrong for that. But to decrease recurrence of episodes, we could give carbamazepine. It's when we have a V1 distribution, the ophthalmic distribution for trigeminal neuralgia, that it can be misconstrued as cluster headache. But as I just harped on, it's going to be a minor stimulus that precipitates an episode for trigeminal neuralgia. It's not going to be a male 20s to 40s being awoken from sleep. Wrong fucking answer. Choice D, gabapentin, wrong fucking answer. So as I just mentioned a moment ago, this in theory could be used miscellaneously for neuropathic pain, e.g. for herpetic, post-herpetic neuralgia. It could be used for neuropathic pain peripherally in the setting of trauma or diabetes. Okay, some patients who are not going to be a candidate for TCAs, because TCAs such as amitriptyline can be used for neuropathic pain as well. But you could just know that gabapentin, classic agent used for neuropathic pain. There's other talking points as far as gabapentin. OMG, it's used for restless leg syndrome now, preferred over D2 agonists such as pramipexole. It's more just mood talking point. Wrong fucking answer. Choice Z, verapamil, correct answer. 9-dihydropyridine calcium channel blocker, with one of its use cases being prophylaxis for cluster headache to decrease recurrences. So as I inculcated, 100% oxygen is going to be used to abort acute episodes in theory, but we can use the non-dihydropyridine calcium channel blocker, verapamil, to decrease recurrences of episodes of cluster headache. Not to be confused with migraine, where migraine, USMLE likes beta blockade, propranolol. Okay. Now, in theory, could you use verapamil as a prophylaxis for migraines as well? The answer is yes, but it's about what actually shows up in the NBME exams. And USMLE likes verapamil for prophylaxis for cluster. They like beta blockade, propranolol, prophylaxis for migraines. They'll give you a woman who's 38 who has high blood pressure and migraines. The answer on the family medicine form is just beta blockade. They won't even write propranolol necessarily. And then migraines, you're going to have NSAIDs followed by triptans for abortive therapy. You know the deal. I'm going to make more content if you like my stuff. Subscribe my channel. Appreciate your time. That's it.